begin with our case 1. So an 11-year-old previously healthy male presented with complaints of respiratory distress and dehydration. On examination, he is very ill appearing, there are sunken eyes, and he appears to be breathless. He cannot even complete one full sentence without taking another breath. But on auscultation, lungs are clear and heart rate is 136 per minute, respiratory rate is 30 per minute. So what is your impression?
Lakshay says asthma. Remember, the chest is, lungs are clear to auscultation. That means the breath sounds are also heard. So it's not a silent chest. So blood sugar, Virender says, and DKA, diarrhea. There is no history of diarrhea. Dr. Vikram has already said that he is a previously healthy male. Pulse Dr. Bhanu would like to know about the pulse. Dr. Nidhi would like to know about the history of polyuria, polyphagia, and GRBS. I didn't get the full form of, is it random blood sugar? G stands for, DKA, HGT, dehydration with metabolic acidosis. So I think we have got certain answers. I think one thing which you should like to know and which I would also like to know from Dr. Vikram, the child is breathless, cannot complete full sentence. You said DKA, but how do we know that this is a acidotic breathing? So I would definitely like to know what kind of breathing, what is the breathing pattern in this child. So Dr. Vikram will tell us about the breathing pattern in this child and then general about the breathing patterns in general. What are the different breathing patterns in a sick child?
Right. So as sir has already pointed out, and some of you have also pointed out that it could be a case of DKA, some say asthma, but respiratory distress is a very vague term. One would really like to know what is the breathing pattern like. So breathing pattern means you have to tell respiratory rate, use of accessory muscles, any adventitious sounds, whether you are getting any stridor, any grunt, any wheeze, audible wheeze is there. So you have to describe the breathing pattern in these terms, right? So whether the child is having only silent tachypnea is there. So silent tachypnea can be there in fever, in dehydration, in pain, in anxiety. So no other signs of respiratory distress, no use of accessory muscle, just the child is tachypnic. So these conditions can be there. Or the child can have long and deep breaths. So these can be acidotic breathing, seen in signs when there is severe dehydration. Paradoxical breathing, the breathing pattern. Usually your abdomen should go out with each inspiratory cycle. But if it is paradoxically going inside, then it is paradoxical breathing, suggestive of diaphragmatic palsy. Then there can be irregular breathing patterns with apnea, suggestive of CNS pathology. There can be labored breathing, where the patient is using all his accessory muscles, suggestive of parenchymal involvement. So you should describe the respiratory distress in terms of all these parameters, like what is the breathing pattern, what is the use of accessory muscles, what are the adventitious sounds. So this particular child has long and deep breaths with fruity odor. Odor is also one thing where you should focus on. So because some particular kind of odors can give you particular clue, like fruity odor is suggestive of ketones or ketosis, while kerosene or alcoholic smell can give you clue regarding particular intoxication. So I think now you would be better able to point out what is the diagnosis, like when I give you this hint that this child is having long and deep breaths with fruity odor.
Okay, so what's the diagnosis? I think now we have long and deep breaths, which are characteristic of an acidotic breathing. So DKA, I think everybody is now clear that this is DKA. It is not diarrhea because there is no previous history of diarrhea. There is no other CNS problem. There is no history of fever, no history of, and it is not a paradoxical breathing. So that diaphragmatic palsy, etc., is also out. What bedside investigation would you like to order in such scenario? Please write in the chat box. What bedside? You are right. This appears to be a DKA, but what bedside investigation? I think this becomes very simple. Urinary acetone, blood sugar, RBS, urinary ketone, VBG, urine ketone. I think all the correct answers are coming forth. So you like to do blood sugar, urine ketone and sugar. One more thing, arterial blood gas. Venous blood gas should be equally good, isn't it? ABG, yes. So I think we've got all the answers right. Yeah. Thank you so much. That's a wonderful participation. Dr. Vikram, you'd like to just summarize what all investigations need to be done.
Right. So now it is very clear that we are dealing with a case of probable diabetic ketoacidosis, and it can be very easily diagnosed at the bedside. You just have to do few basic bedside investigation and you can have results in minutes, ABG or VBG. So ABG is mostly done when you are mostly concerned with the oxygenation status of the patient. Otherwise, VBG is also fine. So venous blood gas in this particular case will do. Then you have to check a blood sugar. So glucometers are readily available. You can check blood sugar at the bedside. And then you have to do urinary ketone levels, which is also very easily available. You have those dipsticks and within seconds the results are available. So within 2 minutes you can make a diagnosis of whether you are dealing with a case of DK or not.
Thanks, Dr. Vikram. So again, back to students, you have made the diagnosis of DK. So can you just give me 3 criteria on which you base the diagnosis of DK? 1, 2, 3. Please give me the diagnostic criteria. How do you define DKA? That is my question. How do you define DKA? Waiting for your answers to this question. Somebody said pH. Yeah, pH less than 7.3. Blood sugar more than 200. Bicarbonate. What bicarbonate? What less than? Bicarbonate value indicate blood glucose more than 250 ketone per. Bicarbonate less than 15. Wonderful, wonderful. That's nice. Sugar more than. I think that's a complete answer. Urine ketone positive, blood sugar more than 200, pH less than 7.35 from Sritama. So that is the correct answer. So again, thank you very much. So just repeat, the name itself is definition, a blood sugar more than 200, ketosis and pH less than 7.3 and bicarbonate or bicarbonate less than 15 gives you the diagnosis of DKA. So can serum ketones are not easily available, so can urinary ketones be used? Instead, some students have written urinary ketone. So Dr. Vikram, what is your take on that?
Right. So all of you have defined it very rightly. DKA, as the name itself is DKA. So you have to prove 3 things: diabetes, ketosis, acidosis. Diabetes is random blood sugar of more than 200. Ketosis, by definition, it is serum ketone levels. So we have to do serum ketones level, but it is not readily available. So we go for urinary ketones. Then acidosis, pH less than 7.3 or bicarbonate less than 15. However, some authorities also say bicarbonate less than 18. But both are acceptable. We have to prove acidosis nonetheless. The thing is, by definition, DK says that it should be serum ketosis, but we go for urinary ketosis, which is a reasonably good marker, but there are some problems. So whenever there is insulin deficiency in the body produces ketones, right? So by ketones, we mean 3 types of ketone bodies like acetone, acetoacetate, and beta hydroxybutyrate. So the most common is beta hydroxybutyrate, and it is 75% of the total ketone bodies. So that is there in the serum. In the urine, it is mainly acetoacetate. So if you are only measuring urinary ketone, you may be underestimating the ketosis. And secondly, the beta hydroxybutyrate keep on converting into acetoacetate. So sometimes even when the serum systemic ketosis has resolved, you may continue to get ketosis in the urine. So that is 2 shortcomings of doing urinary ketone levels, but these are reasonably acceptable as serum ketones are costly and not readily available everywhere. So you can go for urinary ketones, and mainly you have to manage the patients on your clinical judgment. You have to go for these investigations as well, but mainly the DK patients are managed on your clinical judgment and continuous clinical monitoring.
Okay, some tips for the postgraduates. You all know how to manage DKA, but during this management, there are certain common errors that are committed by the resident on duty, or even sometimes the JR is there. Even they can also commit this error. Anybody can. So I like to ask Dr. Vikram, or should we ask the student, what all you should not do in a child with DKA? I think. Don't tell me what you would do. You tell me what you should not do in a child with DKA. Very good. Starting insulin right away. Absolutely correct. You should not start insulin right away. Not adding potassium to fluid. I think that's a very... so don't... what else? Fluid bolus. Fluid bolus has to be given. Insulin without serum potassium. Okay, so these are suggestions coming to me. I think we'll go to Dr. Vikram, who will tell us now what the residents should not do in a child with, what are the common errors while managing a child with diabetic ketoacidosis.
Right.
Akansha is correct. She said don't correct hypoglycemia. That means don't give insulin before correcting dehydration. Yeah.
Right. So first and foremost, there is no role of insulin bolus. So insulin as a bolus should not be given. See, the patient has come to you in an acute state. So you have diagnosed as DK, but hyperglycemia was there for quite some time. That is to be understood. The patient is already in a hyperosmolar state. And what happens in a hyperosmolar state? How does brain adapts to it? So brain develops some idiogenic osmoles, right, to balance it out. So that happens in hypernatremia also, that happens with hyperglycemia also. So that is the adaptation of brain. Now if you suddenly cause the precipitous fall of blood sugar level, what will happen? The osmolarity in the ECF will fall, but where will the fluid go? Fluid will go wherever the more osmoles are. So the fluid will move into the intercellular compartment. It will lead to cellular edema. So it is just like hypernatremia, where you do not correct hypernatremia very rapidly. Similarly with hyperglycemia, any hyperosmolar states, you do not want your osmolarity to fall precipitously. It will lead to cerebral edema. It will worsen the clinical condition of the patient. So that is first thing. You don't want to give insulin bolus. Then insulin is not to be started. Yes, you will go for insulin infusion, but that even the infusion should not be started before you have resuscitated the patient with fluid. So fluid resuscitation is the first thing you do in a DKA patient. You have to first give him boluses. You have to first revive the patient. And once the patient is stable, once the patient is out of shock, then only you will start the regular insulin infusion. The second common mistake is not looking potassium levels before insulin administration. See, when you are giving insulin, potassium levels are bound to fall. Insulin is the agent which will cause the intercellular movement of potassium. So the potassium is bound to fall with your insulin therapy. So you should be very observant with your potassium levels. If the potassium levels are already on the lower side, you should at the outside you should add more potassium into the fluid, and you have to keep monitoring potassium levels. Then one common mistake is giving bicarbonate for severe acidosis. You should first correct acidosis by fluid resuscitation. Most of the time these patients' acidosis get resolved when you give them adequate fluid. Right? Acidosis, bicarbonate just increase your chances of cerebral edema. So it should be avoided in patients of DK.
And Dr. Vikram, do you always need bicarbonate, or can it get corrected only by fluid resuscitation, the acidosis part?
Most of the time we do not need bicarbonate. Most of the time we do not need. The underlying pathophysiology that the child is polyuric. He's losing so much amount of fluid. When you give that amount of fluid to the body, most of the time that acidosis gets resolved. Right? Then another common mistake is that you give your treatment chart to the sister and you are not monitoring the patient frequently enough. DK patients have to be monitored so frequently. Blood sugars in the initial stage has to be monitored half an hourly. Electrolytes maybe 2 hourly in the initial phase, then 4 to 6 hourly later on. And urine output charting, their breathing pattern, their neurological status, everything. You have to monitor them very carefully in the first 24 hours. You need frequent investigations, frequent bedside tests, frequent sugar monitoring, frequent electrolytes level, frequent blood gases to know whether your patient is resolving or not. So that is another thing which we do not know, or sometimes we miss out. We do not monitor them frequently enough. Sometimes we order that electrolytes morning shift में किया, night में एक बार electrolytes देख लेंगे. We have to do it very frequently.
So thank you, Dr. Vikram. Any queries on that case of DKA? I think we'll just have a minute or two to let the students ask if they have any queries. Otherwise, we will move to case 2. No, sir, means no queries. Okay. Okay, I think I'll count 10 in my head. Idiogenic osmoles. What does that mean, Dr. Vikram?
Okay.
When should we correct the bicarbonate? Bicarbonate, I think Dr. Vikram has clarified. You have to give fluids first, you correct give the fluid bolus, and even after giving fluid, then acidosis remains. Only then it is the indication probably to correct bicarbonate. This query about idiogenic osmoles, Dr. Vikram, like to say anything about? I'm not clear. What does this mean?
Okay. So idiogenic osmoles, these are the particles. So whenever there is a hyperosmolar state in the body, say hypernatremia or hyperglycemia, how does brain adapt to it so that it doesn't get compromised the blood supply to the brain? So the brain cells develops idiogenic osmoles to counter the hyperosmolarity outside, right? So this is the adaptive mechanism by the brain. So they develop these idiogenic osmoles. These are some particles which are generated inside the cells to counter the hyperosmolarity outside the cells, right? This develops over a period of time. So if hypernatremia, hyperglycemia develops very acutely, then the brain will not develop these idiogenic osmoles. They develop over a period of 2 to 3 days. So it is said that whenever the etiology is of some chronic nature, like hypernatremia or hyperglycemia, then only the brain will get time to develop these idiogenic osmoles.
Yeah, Dr. Vikram, next question is any specific inotrope if child comes in shock, and when to give inotrope? Be brief because we still have lots of cases and we are consuming more time in this. But this is a common problem. I think we need to devote some time to this. Any specific inotrope or when to give inotrope in these children?
Yeah, so these patients may also require inotropes if the shock is fluid refractory. See, what is the main pathophysiology here? The pathophysiology mainly here is the hypovolemic shock. So you should correct it by the adequate volume resuscitation first. However, if the patient is not responding or the AKI has already setting in and the patient is not responding to your fluids, then you can go for any inotropes which will cause peripheral vasoconstriction. Like you can go for dopamine or even epinephrine. So these are the two choices for you in a case of DK. Dopamine is good enough. Epinephrine is also has equal efficacy.
But this would be required probably when it is associated with a septic shock.
Yeah, maybe because DK can sometimes be precipitated by associated illness. So that illness may lead to that kind of presentation. But otherwise, mainly it is hypovolemic shock and should be treated with adequate fluid resuscitation.
Akanksha wants to know if the pH is less than 6.9, despite ongoing dehydration correction, what to do? Does such a situation occur practically, Dr. Vikram?
Okay, now I think fluid resuscitation, another pitfall in the management of fluid resuscitation is that we take care of dehydration. So we assume that on our clinical judgment, we assume that the patient is 10%, 15% dehydrated. We calculate that volume and we transfuse that volume to the patient. And second thing is maintenance fluid. So these two things are taken care in most of the situation. The third thing is ongoing losses. Sometimes we do not take care of these ongoing losses. The patients of DK, the sugar is not going to fall within say 15 minutes, 10 minutes, half an hour, 1 hour. The patient is going to be hyperglycemic. So it's still having that polyuria, right? So that polyuria, that ongoing losses also needs to be replaced. So if we take care of these ongoing losses also and we do enough fluid resuscitation, then there is highly unlikely that pH will still remain acidotic. Most of the time there is resolution of acidosis.
Dr. Virender says if acidosis is not improving with fluid and insulin therapy, then it is renal acidosis. Do you agree with that, Dr. Vikram?
Renal acidosis may be there. See, if the dehydration is there for quite some time, then definitely pre-renal AKI may get converted into renal AKI. That is a fact. And if the renal AKI has already set in, then yes, that acidosis may be contributed by by acute kidney injury as well. In those circumstances, maybe you have to go for bicarbonate, but maybe then in very rarely you may need dialysis as well. So these are rare cases. Most of the time, 99% of the times, DK patients arriving in emergency, you do enough fluid resuscitation, you start insulin on time, they will recover, acidosis will recover.
Last question, Vikram, on this case. The last question will be, is steps to reduce insulin with improvement. How do you start? And so a brief about the insulin therapy in DKA, over to you.
Right. So insulin deficiency is the main pathophysiology in the DK. We have to start insulin once the fluid resuscitation is over. So you have to start with insulin. We usually start with 0.1 unit per kg per hour. Some authorities say you can start with 0.05 unit per kg per hour, but usual consensus is you start with 0.1 unit per kg per hour. Now, as you have started the insulin, the sugar levels will go down, right? But we do not right away decrease the insulin first. We have to give insulin. See, patient is going into decay because of insulin deficiency. Otherwise, hyperglycemia you may see in other circumstances also. There is stress-induced hyperglycemia, and even normal diabetic patient, when sometimes you are monitoring them in ward, they keep on having that high blood sugar, but they don't go into decay because they are also receiving insulin. When there is absolute insulin deficiency, then only they go into decay, right? So you have to give them insulin. Don't decrease insulin. Rather, the first step is you keep on adding more sugar. So you start with normal saline. Once the patient is stable, now the blood sugars are decreasing. It has reached to a level of say 250. You add 5% dextrose to your solution. Say if it is go further below, it reaches around 150. You further add 10% dextrose to it. If it is further decreasing, then you may try to reduce your insulin levels. But right at the onset, you have to provide them insulin. You don't decrease insulin with each falling level of the sugar. Rather, you keep on adding more sugar to the fluid.
Thank you.